We're very pleased to welcome Tara Resnick and Mario Sokas this afternoon as our presenters. Tara is a psychogeriatric resource consultant based out of North York General Hospital. Prior to joining the PRC team, she was a social worker in a long-term care home for several years, where she led the behavioral support program and was actively involved in developing the team's capacity to support individuals with responsive behaviors. Mario is also a social worker with the Psychogeriatric Resource Consultation Program of Toronto. He's based out of UHN and has worked extensively with several long-term care homes in Toronto and has been instrumental in supporting the behavioral programs within these homes. Both Tara and Mario are experienced facilitators with several of the key training programs we offer within our behavioral support system, such as GPA and PIECES. If you have any questions for our presenters, please feel free to type your questions or comments in the chat box at any time. We will have an opportunity to share your questions during the last 15 minutes during our Q&A period around 4:45. We often get asked about getting copies of the slides and access to recording. Please note we will be sending these to the participants, and the recorded session will be posted on our RGP YouTube channel. Now, I'd like to turn it over to Mario and Tara to take us through screening for physical causes of behavior using the 5D's of PIECES.
Thank you so much, Helly. And thank you to all of you for taking the time out of your day to be here with us today. We hope that you find today's session very valuable. I think you will find it to be very practical as you take it back to your work settings and incorporate it into your day-to-day practice. So our topic for today is screening for the physical causes of behavior. And we're going to do so using the 5D's of PIECES tool. So we're going to talk a little bit about the PIECES framework in a couple of slides, but the 5D's tool, which again, I think is a really practical tool that you can incorporate into your day-to-day work, comes to us through the PIECES framework. So just a bit of housekeeping before we dive in. So the slide deck will be shared with you shortly following the training. The webinar will be recorded and posted on the RGP Toronto YouTube channel. So that's important to note in case you have colleagues who may have been unable to join us for the live session today. And all of our recorded webinars from the past also live there permanently. So please feel free to recommend it to colleagues or check out our past webinars for yourself. As Helly said, we will have time for question and answers at the end of the webinar. So please type your questions related to the content into the chat. You certainly don't need to wait until the end of the webinar to ask your questions. Feel free to pop them in as they arise, and we will address them all at the end of the webinar. So let's talk a little bit about our goals for today. So firstly, we're going to broaden our understanding of responsive behaviors, better understand the connection between a person's physical health and responsive behaviors. Responsive behaviors are actually called responsive behaviors because they are in response to an unmet need. And when we start to take a deeper dive and look into the physical health of the person we're supporting, we really will have a better opportunity to identify what those unmet needs might be. And then again, we will be introducing you to the 5D's of physical tool that comes to us through the PIECES framework to support the assessment of physical causes for responsive behaviors. So now we would like to get to know a little bit about you. We're going to put up some poll questions. So first question, please. Thank you. So we are interested to hear what your role is. So we'll give you a moment to answer the first question. Okay, so 14% of us are personal support workers, 32% nurses, 5% occupational therapists, 14% social workers, 9% PRCs, and 27% others. So if you feel so inclined, we'd love for you to pop what that other is into the chat box, if you don't mind. Next question, please. We'd also like to know how many years of experience you have working in the field. So again, I will give you a couple of moments to just pop that answer in. Awesome. So Rob says he's a dietitian working with a GAIN team. Amazing. Okay, our results are in. So 15% of you have 0 to 5 years of experience. 22% of you have 6 to 10 years of experience. 30% of you have 11 to 15 years of experience. 11% of you have 16 to 20 years of experience, and 22% have 21 plus years. So just something interesting to note about these results, whether this is your first day in the field or you're part of that 21 plus group, you all have something to contribute. We all have a ton of knowledge to share. We're constantly learning from each other. And we've also had a look in the last poll question about the different minds that are in the room with us. And it's when we bring this multidisciplinary lens to the table is when the magic, I should say, really happens. So please feel free to share your comments and your questions in the chat box. We've also got a music therapist I just checked out. Cool. Okay, have you attended previous webinars in this series? And the results are in. 30% of you have, and this is really interesting, 70% of you have not. So for our friends in the room who have not attended past webinars, please head over to the RGP Toronto YouTube channel. As I mentioned earlier, they all live there permanently, and I think you'll find them really useful. And to the 30%, welcome back. All right, so I'm now going to ask everybody to take out your smartphone, or you can simply open another browser on your computer and head over to the website www.menti.com. Once you're there, we're going to ask you to please enter the code 3299309. So again, that code is 3299309, and we've also put that in the chat box for you should you need to refer back to it. So I'm going to give you a couple moments, and I'd like you to please record your answer to these questions. We were experiencing some tech difficulties in our morning session with Menti, so I'd like to give it a minute to see if it is populating. But if not, this exercise will work just as well, so not to worry. Okay, so I have a feeling it might not be working again. Our apologies for that, but as we know, that is sort of the theme of the last almost 11 months of this pandemic. Technology is not always on our side, so that's okay. So what I'm gonna ask you to do, I think I see Mario actually trying to fix this, be our tech support behind the scenes, but what I'd like to ask you to do is to add up your numbers. So you can see it on your end, we just can't see the results here. So add up your numbers. Tally up your total number from each of your responses. And then I'll help you make sense of what your total means. So if you scored between 1 and 3, this indicates that you have mild pain. If you scored between 4 and 6, this would indicate that you have moderate pain. And if you scored between 7 to 10, this indicates that you have severe pain. So this is an adapted version of what's called the PAIN-AD. And the PAIN-AD is a scale that we use to screen for pain in people who are nonverbal or who might not be able to let us know what their experience is. So it is therefore commonly used in folks who are living with dementia. And as we can see, we aren't that different in our expression as human beings. The difference is that we can tell somebody what's wrong and we can advocate for ourselves to get the support that we need for whatever our physical concern is at any time. Somebody who's nonverbal or unable to express that would not be able to do so, and therefore might actually just be living with chronic pain. So when we think about that, it helps us sort of understand just how powerful this can be when we think about quality of life. We know that pain is one of the most common physical causes for behavior. And as we continue through our presentation today, we're going to be exploring and identifying other possible physical causes of responsive behaviors. So let's talk about the PIECES framework before we dive further in. So PIECES is a framework that's recognized nationally as a holistic assessment framework where we keep the person with dementia or other complex neurocognitive diseases or mental illnesses at the center of our assessment. Many factors contribute to a person who's living with any of these illnesses to exhibiting responsive behaviors. And when we use the PIECES framework, it actually allows us as a team to identify the factors and put appropriate strategies into place that will address whatever those needs are, that unmet need I talked about earlier. As we identify the possible causes, many of them, when we think about it, won't be effectively treated with antipsychotics. So we always talk about in our care for the older adult, reducing the use of antipsychotics when possible. And when we use the example of pain, which we just talked about on the last slide, if somebody is in pain and that's what's triggering their behavior, an antipsychotic is not going to help them. It is not going to treat their pain, and therefore the behavior will never really resolve. All it's going to do is sedate them and probably cause more issues. So we really need to think about this as well when we think about the other causes for behavior. And PIECES, as I said, helps us do that. So first, PIECES asks us to look at the physical piece. And I should mention, actually, PIECES is an acronym. So that P stands for physical. The I stands for intellectual, so it asks us to look for those intellectual causes for behavior. The first E is emotional, which asks us to look for the emotional causes. The C is capabilities, the last E is environment, and the S is that social cultural piece, which we know is so important as well. So for the purpose of the presentation today, we're going to be focusing on the first part of the PIECES acronym, that P for physical, where we're going to look at the physical causes for behavior in more detail. So why do we need to assess the physical? This is the question. So when you think about the work that we do to support older adults who are living with dementia and who may be exhibiting responsive behaviors, it is a lot of work that goes into these really beautiful care plans that we create. Nothing we do is likely to work if we haven't first ruled out the physical and treated whatever that might be, what that physical unmet need might be. We know that older adults do live with multiple medical conditions that can either be acute or chronic. And we know also that chronic medical conditions can sometimes lead to acute changes. So as an example, a person who may live with diabetes can go into a state of delirium because their blood sugars might not be managed well. And then we would therefore understand that the reason behind that acute change in behavior is actually a medical emergency and something we need to attend to immediately. Another example might be a urinary tract infection. If somebody has a UTI and it's left too long and it goes undetected and untreated, that can also potentially lead to an older adult becoming septic, which is also a medical emergency. We also need to look at the past medical conditions that are or were in remission before coming into our care settings. When we think about that, we have to take into consideration if the person was in remission before they came to us, and could it be possible that this illness has resurfaced and that's what's causing the behavior? We also need to consider past injuries. So I think of myself all the time. An example I use is that I broke my leg when I was in my early teens, so many moons ago. To this day, when the barometric pressure is low, I have pain and discomfort in the area of my leg, which I injured, over 20 years ago. I'm able to tell you that. I'm able to ask you for help or support, or, grab myself a Tylenol or whatever it is I need to relieve the pain. But then I think about it, and it fast forward to when I'm in my 80s, if I'm living with a dementia and I'm unable to tell you I've got pain, and as an example, might come to help me change my pants and I kick you, I'm going to be labeled as somebody with responsive behaviors, when really what's going on is I've got pain in my leg and I'm just unable to tell you that, and I need support. So I always think of that as an example. And when I think a lot of us, when we reflect back on some of our past injuries or ailments, it helps us to sort of step into that person's shoes and look for or do that deeper dive into the physical causes for behavior. As I talked a little bit about on the last slide, using antipsychotics may only mask the cause of the behavior, and they may not treat that cause. So if it is a physical cause for behavior, we can give the person antipsychotics as much as we'd like. However, whatever it is that's causing the behavior isn't being treated, the behavior will persist. And that person now, as a result of the antipsychotic use, may start to fall. Or, we'll use me as an example. If I've got pain in my leg and I'm kicking you and you give me an antipsychotic, I'm going to still kick you, but this time I may fall or I might injure myself otherwise because I'm sedated. So, again, thinking about this idea of the non-pharmacological strategies, we know that they're not going to be effective no matter how much amazing work we put into that care plan, unless we address that underlying physical cause and identify it and treat it. We also know that older adults may not always be able to show the typical physical symptoms of some of the underlying causes. However, they may exhibit that change in a behavior. That's the form of communication oftentimes. So as care partners, if we're unable to identify the cause as something physical, sometimes the person might be labeled as, psychotic, or, as I said, having behaviors. And that can also lead to the use of antipsychotic medications. So it may reduce the behavior, but again, it's not treating that underlying cause. So it really is just putting a Band-Aid on that and masking it rather than treating the root cause. And with that, I'm going to pass it over to Mario.
Tara, thank you so much for going over the overview of the 5Ds and thinking about, how we need to do that good thorough assessment in order to find out what that underlying cause is. Otherwise, the strategies that we're putting in place may not be effective. So what are the 5Ds? Well, the 5Ds is an acronym that has been introduced in the PIECES learning framework. For anybody here who hasn't had PIECES training, we highly encourage you, if you're working in dementia care, to get trained in PIECES, because it offers that holistic framework that Tara just mentioned not too long ago. The 5Ds is an acronym introduced in PIECES that's used to leave no stone left unturned when you're exploring the possible physical causes for behavior. When we think about physical assessments that are done, typically we see teams screen for what are labeled as the quote unquote usual suspects. When we're thinking about delirium, urinary tract infections, or when we're thinking about pain, musculoskeletal pain. However, physical causes and identifying them may not be as simple. When we think about the 5Ds and our older adults, the 5Ds will help us guide to identify whether we've explored all the possible causes, as well as draw attention to how each D has implications for the other. They really are interrelated at the end of the day. Thinking about our older adults that we do work with that have dementia, they have multiple comorbidities. And what are the implications of those comorbidities? Well, this chart here, ruling out physical causes of behavior with the 5Ds, really highlights questions we should be asking when we're thinking about assessing the person. And again, how are they related to one another? Whenever we do go through our assessments, we need to identify a possible cause or an area that needs to be investigated under any of the 5Ds. but something that's really important, that when we are identifying a possible cause under any of the 5Ds, it's important that we have an action plan that's going to address that area of concern. So we're going to now look at how the 5Ds are interrelated. Okay, so we're going to ask these questions here. Number one, let's look at the disease. What is that person's diagnosis or diagnoses? Because the person has multiple diagnoses. Do they have any past injuries, or diagnoses, or any medical conditions that were in remission? You know, thinking about, based on what we know about the person's diagnosis, is there potential risk for delirium? And other than the diagnosis, are there any other potential risks for delirium? So again, going back to the example of the urinary tract infection, we know that a urinary tract infection can also be caused if a person has consistent poor hydration and may have concerns when it comes to hygiene in the peri area. Looking at discomfort now, thinking about that person's diagnosis, could there be pain or discomfort that's related to that illness? And when we think about the type of pain that the person may be experiencing, neuropathic pain or neuropathy. And again, there's implications as to how we treat one or the other. So what could be some other sources of discomfort or pain other than the diagnosis? Could it be that the person has ill-fitting clothing that's too tight? Could it possibly be that a person might have an ingrown nail? Again, thinking about drugs, again, medications. And when we think about the medications, are they the right medications that we're using? Are they on the right medications for the type of pain that they do have? Are they on the right dose? Is it enough? Thinking about the medications that the person is on for all their other comorbidities. Are there side effects of these medications that we need to be aware of, or the team needs to be aware of, and the team is looking out for those side effects, especially when a new medication is introduced? Again, thinking about the comorbidities and being on multiple medications, is there a risk now for polypharmacy? Now, thinking about drugs, we got to think about substance use as well. Does this person have a history of substance use? And when was the last time that they consumed a substance? So thinking about people attending this webinar here, whether you work in a long-term care home or in a care setting such as acute care, or even in the community, if you're working with somebody for the first time, or they're coming to you for the first time, never worked with them before, they've had a history of substance use, asking that question, when was the last time that they consumed the substance, is important, because is it possible that what we're seeing is withdrawal because they have now suddenly cut the use of that substance? And finally, disability, thinking about the person's illness, thinking about their diagnosis. What could be some of the limitations that this person could be experiencing because of that? Could these limitations be causing frustration or anger? Can they safely transfer themselves? And could their disability cause any discomfort as well? As mentioned earlier, we have to think about action plans putting in place. Based on what we know about a person's disease, what more information do we need to know as a team to better support that person with their illness? What kind of an understanding do we have about the impact that this illness has on the person and their behavior? And thinking about our team and them needing to know more information, who can support the team with further information? For those working in the community and long-term care, you can reach out to your psychogeriatric resource consultants. Delirium, well, thinking about screening for delirium, and as Tara mentioned earlier, delirium is a medical emergency. We need to really look at delirium because of the potential life-threatening implications it might have if we don't. There's tools such as the confusion assessment method, which is based on the Diagnostic and Statistical Manual for Mental Health Disorders, that offers screening for delirium, not to diagnose delirium, but it helps us raise that red flag. And supplementing that tool with the iWatch Death tool, and this comes from Pieces, each letter for iWatch Death stands for a potential cause for delirium. And relating that tool to a person's diagnoses can really alert us to what areas we need to screen further as far as delirium is concerned. Do we need to look at other assessments that need to be done, such as lab work, urine, x-ray? Do we need to get in touch with the doctor? And if we are unable to really do that assessment in-house or in our settings, does that person need to be transferred to the emergency room for further assessment? And hopefully at an emergency room where there are geriatric emergency management nurses or GEM nurses. So thinking about discomfort, what tools does your organization use to screen for pain, especially for people who are nonverbal and may not necessarily be able to tell us what their experience is? So thinking about the tool like the pain ad scale, and that's used on people who are nonverbal, whether the person has dementia or has aphasia because of stroke. Getting that information from that pain ad scale can raise that red flag, what further investigation needs to be done in order to treat this person for pain. Thinking about what medications or treatment the person is actually on. And again, the medications have to tell us, are they on the right dose, the right medication, and treating the right kind of pain? And have we explored all other medical causes, such as tight clothing or shoes or fabrics that might be feeling uncomfortable? Again, these are the action items, asking those questions to ensure we're getting to the right action item. So what we're thinking about medications and drugs, what referrals need to be made to look into these medications? Does this person need the doctor to look at it? Does the pharmacist need to go over the medications? In Ontario, homes have access to geriatric mental health outreach teams or GMOT teams or psychogeriatric outreach programs or POP teams. If it's pain that's the issue, do you have access to pain consultation services and supports in your regions? Finally, disability. Have they had a physio assessment, occupational therapist for mobility aids, an assessment there as well? Would they benefit from a restorative program to regain capabilities? And would they benefit from assistive devices such as for eating and for drinking? So again, when you're doing your assessment, make sure that you have an answer in your action item. So do take action. Just to show you how the 5D's are interrelated, let's talk about diagnoses of diabetes. And we know we in long-term care and in our older population, we have quite a few people that do have that diagnosis. I've come across it in the years I've worked in geriatrics. So diabetes is the disease. When we think about diabetes, there is a risk of that person becoming delirious or potential risk for delirium because of hyper or hypoglycemia. There is discomfort associated with diabetes. We have diabetic neuropathy. Thinking about medications or drugs, we've got to look at the types of medications that they're on, and thinking again about the diabetic neuropathy. Are they taking something that will manage that? But thinking about medications and drugs, could that be the reason why the behavior is happening as well? I'll never forget, we had a younger resident at one of my facilities where there was a code white being called on him almost on a daily basis because of his behavior and because he was getting into that sudden state of psychosis. Medications have been changed many times. And what we did notice is that even at a baseline level, his diabetes was not well managed. His blood sugars were not well managed. And so when he escalated, if he allowed for when he started to de-escalate a little bit, and we were able to check the blood sugars, they were significantly high. So what we discovered was the insulin dosage that he was on, it wasn't enough. It was pretty low for a person their size and also their age. And so what ended up happening was the doctor bumped up the insulin dosage, and it was months until a code white was called. So we discovered that the reason behind his sudden state of psychosis, he was in delirium, and it was because his diabetes was not being well managed. And finally, let's look at disability and diabetes. In the same person, unfortunately, because his diabetes was not managed for many years, even prior to going into long-term care, this person ended up developing glaucoma, which is an eye condition, and this person's peripheral vision was now gone, which does implications on how we needed to be approaching this person, not from the side, but more from the person's central vision, so they're able to see us. So as you could see, the the intervention strategy wasn't about antipsychotic medication at that point. Even just simply how we approach the person made a difference. So as we could see, simple diagnosis like diabetes does fall under the 5Ds. So what we encourage you to do is thinking about the teams that you work with, taking the 5Ds and some of the other comorbidities that the person has, and how could they possibly fall under these Ds, and what needs to be further investigated. So we're going to show you a case study here right now, and it really outlines the importance of managing the physical causes for behavior. As we go through this case, I want you to think about what are some flags that you're raising as far as possible physical causes for this person's behavior is concerned. I should mention that this is actually a resident that I worked with in one of my long-term care homes. Of course, I changed some of the indicators, so you're not able to identify. There's no identifying indicators on this case. So we're going to call her Mrs. P for the sake of this case. So you're working with her, who's 84. She's 85 years old, has a diagnosis of unspecified dementia, moderate to later stages, diverticulitis, osteoporosis, diabetes, Parkinson's disease, and oral cancer. She's currently on about 50 milligrams of Seroquel 3 times daily, 1,000 milligrams of Tylenol 4 times daily, and from what I heard, that is quite a bit and maybe a little bit too much. 75 milligrams of Cinnamate, insulin, but refuses her blood sugars to be checked and refuses her insulin, and she's also on lactulose as well. She has bowel movements every 3 to 4 days, medium in size, formed, and texture looks quite hard. So keep that in mind, and we're going to see what the behaviors of concern are with Mrs. P. So Mrs. P's behavior is she does not allow members of the team to change her incontinent product when she has a bowel movement, and she'll be pacing in the hallways with her walker soiled. If staff try to change her, she'll hit them when they touch her or move any of her limbs. She has also lost greater than 5% of her weight in the last month as her intake is poor. She eats about 25 to 50% of her meals, regular texture, but members of the team report she eats more of the softer textured foods on her plate. Her fluid intake is poor as well. When Mrs. P is not soiled, she still paces in the hallways and you could hear her moaning. You can hear her moaning. But when you ask her what's wrong, she just looks at you for a moment and then continues to pace. Today, you find her pacing faster in the hall, screaming and crying. She's also pointing at the walls and makes incoherent noises, screams, and then walks away. You also notice that she's not walking with her walker. This is something that she has never done before. So have a look at Mrs. P. And I'm hoping the Mentees poll works, but if not, please in the chat box, if you could type in some of the red flags that you've raised that may be possible physical causes behind Mrs. P's behavior. She has quite a few concerns that have been listed over there. I can tell you that the team was quite distressed when they were working with her. They were trying to figure out what was wrong, and they tried changing antipsychotic medication, and that wasn't taking care of the problem. So let's hear some of it seems that the Mentee poll is still acting up today. So I would encourage you in the chat room, and again, all panelists and attendees, so we can all see your responses. All right. I'm seeing arthritis. Okay, oral cancer, pain, constipation. Yes, a lot of the answers are coming in. Yeah. Pain, constipation, delirium. Yep. Many of the health concerns are listed. Yep. Hyperglycemia, yes, could be UTI due to low fluid intake and refusal to change briefs. Excellent. And I like to mention that I like the hyperglycemia. Delirium was mentioned, so hyperglycemia and the UTI would fall under that category. The osteoporosis, yes, diabetes could be that she's hungry as well. Yeah, yeah, she could be hungry. You never know. Like her intake is quite poor. Delirium secondary to constipation, UTI, dehydration, dysphagia. Yes, she's not eating properly. The poor hydration, yes, the poor hydration can lead to dehydration. So we do have quite a few concerns here as far as Mrs. P's physical health is concerned. We're seeing pain, possible delirium. It could be that the fact that she's not eating well and she's hungry. The diverticulitis flare up as well. Absolutely, yes. Diverticulitis is quite painful. And the thing is, we also have to take into consideration, is the lactulose enough to really clear the bowels out? So the thing is, we ended up having to send her to a hospital because of the urgency of the situation. So yes, she did have a urinary tract infection. Her blood sugars were off as well. They got her medically stable, and what ended up happening is when she came back to the home, something that they meant. I'm glad somebody mentioned the hunger. What happened was there was a referral that was made to the dietitian to change the texture of the diet, so the softer texture foods made it more comfortable for her to eat. But then they revisited the pain management as well. She was started on something a lot stronger for her pain. They moved up to eventually she reached a hydromorphone. And so what happened was her pain was all managed. Her intake improved because of that. Her intake also improved because of the soft texture diet. And she was more approachable as well. She was allowing staff to start to care for her as well. It's because she wasn't in so much pain. The good news is she did much better in that respect. The bad news is it wasn't that long after that she passed away because unfortunately the cancer metastasized and she ended up passing away. Uh, However, the team and the family was at peace with the fact that she was no longer suffering. Her pain was being managed before the ultimate time came where she passed away. So there was a little bit of a happy ending to that story in the sense that she was more comfortable, and also her oral intake improved as well. So as we can see, with just looking at this case, there was so many reasons why this was happening. We're thinking again, her diagnosis and her disease, many of you mentioned it, thinking about discomfort, the medications that she was on, and the fact that she was delirious as well. As we went through this case, we identified those multiple factors and we saw that those Ds were not necessarily isolated from one another. So when we're first identifying a behavior of concern, it's always important to ensure that we've identified all possible physical causes and we've really taken that deep dive into the physical causes using the 5Ds. And that we have enough information and enough to go on to really manage the concerns that we've identified. The thing is, though, a lot of the times, especially depending what setting that you're working in, like acute care or a new resident in long-term care, or even a new client in the community, sometimes we don't have enough information initially. So if we don't have enough information and we're seeing behavioral concerns, let's look at what this person's disease or diagnosis is. Let's stop and look at what this person's disease or diagnosis is. And what is it telling you about what their physical experience could be and what are some potential risks as well? Stop and look at that and think about how this can give us that information to guide our physical assessments. We just wanted to thank you for being here today, taking the time for joining us, but most of all, for supporting persons living with dementia in your care settings. You're doing very important work, and so we just wanted to say thank you, especially during these unprecedented times. So we would like to hear from you. A link is going to be posted in the chat room, chat box. You will be receiving that link. and it is for the Survey Monkey for you to provide feedback. But also, we are interested in hearing from you as to what are some potential future webinars that you would like to see us present on. We welcome all your feedback. So again, thank you, and we're going to be taking questions right now.
So thanks, Mario and Tara, for taking us through, I think, a really eye-opening exploration of how physical conditions can really contribute to responsive behaviors that we may be seeing. So we do encourage you to put your questions into the chat. As you may be putting in some of your questions, I wanted to ask if Mario and Tara, if you could comment a little bit more about the CAM, the confusion assessment method tool, which you mentioned a little bit earlier in terms of a potential screening tool for delirium.
Okay, sure. Thanks, Sally, for the question. When we think about the CAM, it is a screening tool, so it's not a diagnostic tool. I think it's important for us to identify that. But when we're working with our frail seniors and we want to ensure that we get an assessment done or an order for an assessment done, the CAM is a great tool to use to raise the red flag for delirium. We're looking at, in order for a person to have a positive CAM, they have to have an acute onset and inattention, plus one or two of the following, which is disorganized thinking and altered level of consciousness. So they have to have both of the first two and one or both of the second areas as well. The thing is with the CAM, once you raise that red flag for the CAM and that this person may possibly have a delirium based on the results of the CAM, I would do an I Watch Death tool with the CAM, because again, we want to ensure that we're looking at all possible causes for delirium. Quite often in all the years that I've been supporting teams with older adults, we've seen we've asked the questions about delirium, and the first answer I get is, well, we've checked their urine and their urine came back clear. Well, as we can see, I Watch Death, again, I is for infection. What about the other areas? Could the person have low oxygen or a hypoxia? Could it be that they have a vitamin deficiency? Could it be that their thyroid levels are off? There could be so many different causes for delirium. So again, based on what that person's diagnosis is telling you, see, are there other areas under the I Watch Death tool that maybe need to be queried further?
Okay, thanks for that review. I also wonder, this morning you talked about another scenario that you were aware of, where you talked about a woman who actually ended up having a diagnosis of diverticulitis, but she went through quite a process in terms of them trying to figure out what was going on with her. I'm wondering if you could share that story with our afternoon group.
That's my prize story, I gotta say. Well, no, it's an unfortunate situation that the person had to go through that. But it really speaks loudly as to why a good physical assessment it needs to be done. I'll never forget this resident in a long-term care home. She was in the home for about 4 months, and in those, I think it was about 3 to 4 months. And I can't begin to tell you how many times her antipsychotic medication was changed, because the behavior that she was exhibiting was that she was pacing up and down the hallways, and she would yell at people, and it was pretty incoherent. You couldn't understand what she was saying. She sometimes would push people as well. She was in this state of distress for the majority of the day, I would say, and there was no rest in sight for her, unfortunately. So they called me in for a consultation and with the team to understand what could be the possible causes. And the first question I always ask, again thinking about the pieces framework, is, have we ruled out all the physical causes? The answer was no, because unfortunately she would not let the team get close to her to even do a good physical assessment. And given the urgency of underlying physical causes and how it could potentially lead to somebody's death, we felt that it was warranted that we have her transferred to the hospital, to the emergency room. And she was transferred to an emergency room where they had a good geriatric emergency management program, or GEM program. And they of course had to sedate her in order to do the assessment. But what they discovered was, when they did the thorough physical assessment, that when they did the bowel scan, they found that she had they were able to diagnose her with diverticulitis, and they were able to clear out about a year and a half's worth of feces from inside of her. So she had, I don't know how many extra large bowel movements by the time her hospital visit was done. She got sent back to the long-term care home, and then we really had to look at her antipsychotic medication and change it because it was changed so many times that even affected her behavior. But once we had her physical health in check, we had a good bowel protocol put into place following her diagnosis of the diverticulitis, as well as changing her diet too, and changing her antipsychotic medication to the appropriate levels. She became like the model resident. That goes to show you how many times we changed that antipsychotic medication and it didn't work. It was that underlying physical cause of a year and a half worth of feces inside her. That does sound very painful if you ask me.
Oh yeah. And if I can, I just like to share a quick story as well from my time in long-term care, because it's something we wouldn't have always jumped to first or considered first. It's a short story. There was a resident who didn't have responsive behaviors most of the day. Every single night when staff helped her get into bed, she would start screaming, gripping onto the sides of her bed, banging on the walls. And long story short, what was happening is she had COPD, and when she was laid flat, she was short of breath, and she couldn't tell us that. And what's interesting is when we think of the discomfort piece, as well as the disease piece of the 5Ds, when somebody's screaming in bed, the first things, those usual suspects you would think of would be loneliness, maybe fear of the dark, hunger, pain, because they're lying, like you're thinking they're putting pressure on something, and that's what it was. It was the COPD. So whenever we talk about the physical causes, I always think of that poor woman. As soon as we elevated the head of her bed and got that into the care plan, never screamed again. And the most important part was she was comfortable and she could breathe.
And look at that, simply raising the bed. That was the solution at the end of the day.
Yeah.
Yeah. Thanks for sharing that story, Tara. It reminds me, I've heard of COPD also being sort of underlying some behaviors staff sometimes encounter in the shower when people are then having difficulty breathing in a steamy shower room. So I think the case examples you both have shared really help to sort of highlight the importance of that thorough physical assessment to help us to rule out that as one of the possible reasons why we may be seeing and hearing about some of these responsive behaviors. So I'd like to thank you both again very much for this learning opportunity for everybody. And I'd like to thank everybody for joining us this afternoon. As a reminder, you will be receiving a short evaluation survey by email. So please do take a few minutes to fill that out. We really do find your feedback very helpful. Also, if you have ideas for future webinar topics, we'd love to hear from you. And so I'd like to again thank you. Have yourselves a nice evening. Stay safe, and we hope to see you here again soon. We're going to sign off now.
Take care, everyone.